Welcome to the chest imaging. So this one's going to be everything but x-rays. So this is just so you can sort of have a better idea of chest CT scans, lung perfusion studies, things like that. So this is going to be a way that you could be a lot better versed in the diagnostics of things other than chest x-rays, which CT scans are becoming more and more common in the pulmonary and critical care world, not only for diagnostic, but also for therapeutic images. And you even see them with studies out there. So this is not a bad area to have a little bit of focus. So let's get started. Now, most of this is from Wilkins chapter 10. So if you're wondering, that's where it's coming from. All right, CT, we'll start with the easy one. CT scans is pretty much like sliced bread. It's a 3D X-ray for the most part, and usually just your standard CTs just do 1 to 2 millimeter thicknesses slices, just like slicing a loaf of bread, right? So they're standard and high resolution. However, this might be more historical at this point because most of them are now coming to the point where they're almost all high resolutions. So we'll go over a little bit about the difference between standard and high resolution. However, just understand the technology is getting better and better as we're recording this, and you'll probably see mostly high-res CT scans out there. So when you're just reading a CT scan, the big thing to remember here is that the image is mirrored. So what does that mean? So it's like Facebook Live. If you've ever seen Facebook Live, everything's sort of mirrored. It's a reverse side. So if you hold up your right hand on Facebook Live, everybody will think that you're holding up your left hand. So when we're looking at this picture here, you see the spine down here, and up here would be the sternum, right? You can see the sternum, and here's T2, T3 on the spine. So you would assume that if this patient is supine, laying on their spine, that this would be the right lung, and then this would be the left lung. However, because it's mirrored, like I said, this is actually the left lung, and this is actually the right lung. I hope this makes sense. It's just a mirrored image. You're still going to have your orientation, but you just got to understand which one's the left lung and which one's the right lung, because most of the time when we're looking at these as respiratory therapists, what are we looking at? We're looking at the lungs. So it's important to know which lung we're looking at. So if we're looking for, if we're going to do an EBUS, if we're looking for a mass that's in their lungs that we're going to go in and get with a bronchoscope and get samples and stuff like that. We need to know which lung it is in and how far it is and all that other stuff. So this is the big thing. Remember, the image is mirrored. So when you're looking at this, look at your landmarks. Identify the spine, identify the sternum. Here you even see collarbone. I'm circling them here. You see the collarbone coming into the sternum. Right, and so you're starting to see some of your different landmarks going on here. And when we're looking at this, you just got to remember the left and right are flipped. That's the big deal here. So when you're looking at CT scans, look for anatomical landmarks, just like I was identifying. You got your spine and your ribs that curve down here. Right, intrapulmonary, extrapulmonary, these are a lot easier to see on a CT scan than you can on a chest x-ray. That's why these are becoming more and more popular, right? Especially when we're looking diagnostic, like things like bronchiectasis and stuff like that. So we're going to look closely at the whole film. We're going to travel slowly through the whole thing. And so I'm going to go over that with you just so you can start to see some of the landmarks. All right, so this is the start. So here we got the spine, and up here at the 12 o'clock position, we got the sternum. 6 o'clock is the spine, and you can see the spinous process here, right? So when we're looking at this, you can even see the scapula down here, right? I'm trying to outline these things for you. So you can sort of see this patient is lying supine. These dense things are muscles. The opaque, almost white thing is bone, right? That's why you see the sternum and the spine and the scapula are pretty darn radio-opaque. But this other tissue, this light gray tissue, that should be muscle tissue that you're looking at there. So here we have obviously a rib coming around from the spine. So we're pretty high up. Here's the aortic arch area, so we're pretty high up. We're pretty high up in the apices, and yeah, here I'm highlighting that aortic arch that comes up and over. when we're going through this whole thing. And here obviously is going to be your trachea. So as you're going down, if you see a mass that shows up like right here, then obviously that would be like a tracheal mass or something like that. Or if you see a bunch of coin lesions, you would see them up here. But most oftenly, remember, coin lesions or lung cancer or things like that happen in the right upper lobe than the left upper lobe. So that would be, remember, it's a mirrored image. So which lung is the right lung? Yeah, this is the right lung. This is the left lung. Okay, so remember, it's a mirrored image. Even though we identified our sternum and our spine, they're flipped, right? The left and right are flipped. And so this right lung is over here. So if we're going to see any coin lesions or anything like that, traditionally, those are in the right upper lobe with that airways, the three segments up there, the apical, posterior, and anterior segments up there. And so if you see something in the right side, which would be on the left on this, oh heavens, right? If you see a coin lesion up here, then that's something that we'd see when we go in to do a bronch procedure. That's probably an area that we would target. So this is just the same picture, and this is just showing how superior we were, right? We started to see the aortic arch, right? We identified that. We started identifying the apices when we were looking through there. We've seen some of the ribs, right? So this is just giving you an orientation of the landmarks of where we're at. So we're moving down. Here's a better picture because we're moving further down. You can see the aortic arch. A lot easier. A lot easier. Here's your superior vena cava that drains from the jugulars, right? They drains from the jugular veins down into the superior part to get dumped into the right atrium. All right, so we've identified the spine. We've identified the sternum, right? It's actually marked sternum here. Which side's the right lung? Hopefully you said it was this one, so that would mean this is the left lung. Notice that you're starting to see the cardiac silhouette start to show up. Do you guys start to see this, right? I'm trying to outline it for you. So this would be the heart silhouette starting to show up. Remember, the heart's mostly oriented to the left side unless someone has like a dextrocardia or something like that. So we're starting to see the right lung, the left lung, the sternum, right? And we're moving slowly down, right? You can still see the scapula. You can still see those. So we're still pretty superior overall. Right, and so this is where we're getting closer. Notice on there, we had one giant hole in the middle there, and that's looking at the carina. That's right there. And so we're getting closer and closer to the carina where we'll split into the left and the right lung. We've seen the aortic arch a lot more prominent here, so we're just moving on down. All right, so now we're moving down, and this is just a different way. So this is the same CT scan. They just put some color to it, so that way it might be more identifiable to you when you're looking at it. Let's see, should I use bright yellow? I use bright level. All right, so this is showing the ascending aorta and descending aorta. So the arch, we just went through the arch, and now we're seeing the two bottom parts of the arch, the ascending aorta and the descending aorta that goes all the way down to your legs and everything. So we're just identifying over here, the superior vena cava, right? We've already seen that. And over here, same thing, descending and ascending aortas, right? Now here, remember which side's the right lung, which side's the left lung. Remember, this is the right lung, and this is the left lung over here. So when we're looking at this, you're going to start to see the right main stem bronchus appear and the left main stem bronchus appear. So here is the carina in between these two, right? That's the carina. As we're going down, notice the scapula have disappeared at this point, so we're getting further down there. The pulmonary trunk, that's this thing here. If you're looking at the left picture, on the right picture is actually marked pulmonary trunk. Right, this is the pulmonary artery where the deoxygenated blood gets sent to the lungs. And you're going to see it appear in the left side first, traditionally, as long as the patient's not oriented in an abnormal way. You're going to see that appear first, usually in their left lung. Now over here, on the left picture, you can see that oblique fissure start to form in the left lung. Remember, left lung only has two lobes, and it's separated by that oblique fissure. And over here, on the screen on your right, you can see they actually talk about it there too. They label it there for you. So here, anteriorly, or according to this picture, superiorly, is the upper lobe. And anything below this oblique fixture is the lower lobe. So now you see the left upper lobe and the left lower lobe. So you're seeing segments here go into the lobe. Pretty cool. So this is pretty much the same picture, but this is without all the color on it. Here you see the ascending aorta. Here you see the descending aorta. Here you see the pulmonary artery, aka the pulmonary trunk. Here's where you see how this is curved up and down. I'm exaggerating it here, but you see this little spike here. If you rewind it a little bit, that's where we're separating. We're getting to the point of the carina where we'll separate into the right mainstem bronchus and then down into the left mainstem bronchus. That's what you're seeing here. Here, do you see the fissure? No, it's harder to show up because the density value is a little bit different. But hopefully you can start to see some of these things appear. Remember, with x-rays and CT scans, it's pretty odd because you have to look at them a lot before you really get the hang of it, unfortunately. And then up here, you start to see the cardiac silhouette start to show up. Alright, so we're moving on down. We're going to be below the carina on this next film. You can sort of see just orientation of where we are. And here we're at. We're getting down there. You see the right bronchus, the left bronchus. Remember, this is the right lung. This is the left lung, spine, sternum, right? Look at your orientation, ascending aorta, descending aorta, and then pulmonary trunk is starting to look like a good divide here. So if we're looking for a saddle embolus, and one of the things we can do is a CT with contrast to look for a saddle embolus, we're going to be looking at this, and we'll give them a dye. And what you don't want to see is dark area up in here, and so we're just assuming it's gone to the right branch. If you see dark area and the rest of this is light gray, that's a sign that that's where that massive blood clot or whatever it is hanging out right there. And that would be one of those like saddle emboli type situations going on. So that's where you would look at the with contrast, and you might be able to catch it there. All right, so this is sort of the similar picture. Once again, we have the sternum, the spine, let's go yellow, the right lung, the left lung, ascending aorta, descending aorta, and they highlight all this stuff for you. The right bronchus, the left bronchus. Notice that the left bronchus looks more oval in a shape. Why is that? Think back to pulmonary AMP. What are the angles of the right and left mainstem? Should be 25 and 40 to 60 respectively. So this one's going to look more like a circle. Then your left lung's going to look more like an oval, because remember, it's a flatter angle. It's that 40 to 60 degree angle depending on how tall the person is, but that right mainstem's usually around 25 degrees or so. So that's why they look sort of different there, and that is one way to sort of start telling the difference as well. So you have your superior vena cava up here, and then you're going to start to see your pulmonary artery here. Okay, so as we're moving down, they label a bunch of this for us. So they already labeled right bronchus, left bronchus, descending aorta, ascending aorta, superior vena cava, where that jumps out. And then we're starting to see the top part of the ventricles. So we have the left and right ventricle. The right ventricle you might see before the left ventricle. The left ventricle is sort of a little bit lower because it has more mass into it usually. You can see the right ventricle. The left atrium is starting to appear in this picture here. You can see a little bit of the esophagus down here, and they're just trying to show you that. Remember, this is the right lung, and this is the left. And remember, your heart's more on your left side anyway, so that's also a cheater's way of looking. If you don't remember that it's mirrored, which side is the heart mostly in, and if they don't have dextrocardia, that could be a help to you as well. Alright, so this is sort of similar to what we're looking at before. Now we're starting to see more of the fissures start to appear on the sides here. We can see the esophagus posterior, right? Because we're below the right and left main stem, so the only tube that's still going down there is the esophagus. Here you even see the azygos vein, which is awesome. If you go back to pulmonary A&P, which I know you all remember like it was 26 years ago, you're looking at the azygos, the hemiazygos, and the intercostals that drain back into the heart. But when we're looking at the descending aorta, that's where the blood's going down to the rest of the body. And now we can start to see the heart a lot better on a CT scan. So you can see the right atrium, the right ventricle, and then you can start to see the left ventricle. And notice how muscular this whole left ventricle is, or this whole left side is there. That's pretty big, right? You see your interventricular septum, the apex of the heart down there. You see how strong and big that muscle is, right? And that's usually a big sign there, and that's one of the ways that they could also look at for things like cardiomegaly and all that stuff in here. Right? We're still moving down. We're moving lower and lower to the point where we're going to see the right dome of the diaphragm, because remember, on the right side, that hemidiaphragm on your right side is higher than your left because of the liver. And that liver pushes up and restricts that right lung from a little bit of expansion. So that's what you're starting to see there. So if you start to see that circle appear in the right lung, remember this is the right lung, this is the left lung, you start to see that appear. That's where you would start to see that liver show up. Here's another better picture of the heart and how strong and massive that left ventricle is, especially compared to the right ventricle. Has some meat to it, but not very strong. IVC is the inferior vena cava. You're starting to see that show up. If someone had an IVC filter in place, in theory, you could see it here. Sometimes you can, sometimes you can't. It just depends. And those things are not as common as they used to be because of, a lot of issues, but that's a whole separate situation. Here you also see the esophagus still there, the descending aorta. So when we're looking down, we're getting closer and further down, and that's all that middle picture was just showing you roughly where we were at. We're still seeing the bottom part of the left ventricle, so now we don't see any of the chamber anymore. We're just seeing all the meat or all the muscle, the myocardium of there. Now we're starting to see more of the liver start to appear and less lung tissue, and now we're starting to see the dome of the left, the bottom of that dome, the apex of the diaphragm on the left side start to appear. Here you still see the descending aorta. Here we're around T8, T-spine 8, esophagus much bigger as we get further and further down. Vena cava, inferior vena cava much bigger as we move down, right? So this is just showing you what it's looked like as we're moving down and down and down. So when we're looking for diseases that affect mostly the bases, like ARDS and things like that, this is sort of that screen where you're going to see most of the atelectasis. You're going to see most of the lung compliance problems as far as decreased compliance down here towards the bases. Remember, the apices are really what's affected by cigarette smoking and emphysema. And so that's going to see more in the apices, so we would have seen that earlier on. And then when we're looking at like blebs and all that stuff, those are more likely apical as well. Right, so this is what it's going to look like when you're looking at just the straight black and white version of it. You're going to see the heart sort of disappearing. Right, you see the descending aorta, and then you start to see the dome of the, remember this is the left lung, this is the right lung. You start to see the dome of the left side, the left diaphragm start to appear, and here we already see the liver coming through. Our inferior vena cava is coming up through the thoracic cage. Remember, the inferior vena cava comes up on the right side. That's why it looks like it's right side oriented compared to the spine. And so that's one of the reasons why if you roll someone, let's say you're coding someone that's in their third trimester of pregnancy, you'd want to either displace the fundus towards the left side to get the baby off of the right side, so that way there's better return blood flow to the to the heart for chest compressions, things like that. So vena cava is a big thing here, especially that's that thing that also gets crushed when people are using too much pressure or too much tidal volume during mechanical ventilation. It's more likely that the vena cava is getting crushed and affecting cardiac output with high mean airway pressures, with high peak airway pressures, right? It's more likely that that's getting crushed than it is your heart, because remember, what's more compressible, a vein or a muscle, right? Which one do you think has more mass? Which one do you think has more structure, a muscle or a vein? Even though it's a big vein, it's more compressible, and so that's one of the big worries you have, is crushing the vena cava. And especially when we start talking about CVPs, and looking at your patient's central venous pressure, whether on mechanical ventilation, can be a big indication of mechanical ventilation blunders that are going on. Or it's a good way to optimize mechanical ventilation once you understand what the hemodynamics are doing with your patient, and then what lung compliance has done recently. As we're going down further, so this is around T10, that's what's showing on the picture on the right, we're going to start to see the esophagus open up to the stomach, right? See all the rugae and all that good stuff in there. That's what you're looking at here. You see the descending aorta, and the esophagus is emptying into the stomach, at least we hope so. And so that's what we're seeing here. We're seeing mostly liver, right? This whole thing up here is starting to see liver up here, and then you still see the very bottom parts. Remember, your lungs are that 3D thing, they hang down further in the back or posteriorly. So now you're seeing the very back of the lung. If someone has a ruptured spleen, let's say you work with traumatic victims at like a level 1 trauma center or something like that, ruptured spleen, you might see a lot of mass here in this spleen area, a lot of blood and stuff like that. It would be very radio opaque. Yep, and that's what you're looking at here. Here it's a light gray, but it would be even darker there. And here, especially in that left lung, you see how down here in that left lung, see how it's a little bit more alactatic compared to the right lung? The right lung looks pretty darn patent. It looks pretty darn open. But here we're starting to see some atelectasis, because this is where the border of the lung is, right? So you can sort of see this whole area in here is just sort of closed in. Why is the left lung, especially if a patient is supine, why is the left lower lobe in this segment, in this area, consolidated? Hopefully you said things like, oh, the heart, the stomach, all those are pushing down on that thing. Yeah, all those things are pushing down. So if you ever want to sound smart when you're looking at an x-ray or CT scans, oh, yep, there's a little bit of atelectasis in that left lower lobe, right? Probably not wrong when you're looking at that. Here you can see how big the liver is, especially if someone has liver lacerations. If we're looking at trauma victims, you can see the stomach. And then here's that spleen that we were looking at before. It'd be even brighter. All right, so this is a lateral view. So here, back here is the spine, and up here would be the sternum. So here would be your aorta. I'm trying to highlight these for you. Obviously your heart. So the patient's faced that way, right? Their nose would be that way, the sternum, their spine would be back there. And then you can sort of see their stomach opening up, right? You can start to see this, and then this is where we've seen that consolidation posteriorly here. That's that atelectasis and everything in there. You can see their pulmonary artery. You can see their descending aortic arch to descending aorta. You can see the heart. This can give you a lot better picture too of a retrosternal airspace for people that have barrel chest, like COPDers, right? Some of those chronic hyperinflation patients as well. So this can be a very important slide, especially when we're looking for alternate things as well. So just so if you see something like this, you sort of have a feeling of what you're looking at. So let's talk a little bit about high res versus regular CT. Like I said, regular CT is becoming more of a thing of the past as of this recording. So not something I'm going to stress in depth, but something you should be aware of. Regular CT just creates slices at defined intervals. It's not as clear, but it will pick up everything. All the data between the slices gets placed on the next slice. So it sort of combines the in-between stuff to the next one, to the next one, to the next one. So it's not as clear or clean or crystal clear of a picture, but everything gets picked up on it, right? So all the data between the slices gets placed into the scan at some point, right? It volume averages is what this is called. So it puts everything in here and it sort of blends it together and puts it on that next slice. When you press the side arrow or whatever you do with it when you're scrolling through it, it puts it all into the next slice. So it's not going to be as clear as a high-res CT scan. The high-res CT scan also does slices, but much better resolution because it only looks at what's in those individual areas. It doesn't volume average. It doesn't combine them. And therefore, it's going to be a much better resolution. You can get actual data from that area, right? If I have a mass or a tumor and this slice catches it, then I'll be able to see the exact diameter of it. I'll be able to see the exact size of that slice. And that's a big advantage there. Much clearer picture, much better picture of the lung architecture if we're worried they have a disease. So high-res CT scan looks better at lung architecture. Great for things like ILDs, pulmonary fibrosis, right? Anything that's ILD, that would be a high-res CT scan situation. Emphysema, great for emphysema. Bronchiectasis, remember you have to have a CT scan with bronchiectasis or to diagnose bronchiectasis. GGOs, ground glass opacifications, that's where we're looking at ILDs. As well as things like ARDS and all that stuff. You can see a lot better in high res. Any type of infection that's not responding to therapy, we could either do a bronch or high-res CT, something like that, that can give us a lot more information. And so high-res CT would give us a lot better picture of the infection detail of, let's just say it's like a fungal pneumonia, like an aspergillosis. If we're looking for an aspergillosis, we're going to be able to see that a lot more detail on high-res CT than we are a regular CT. So the regular CT is good for nodule size overall. So let's get over and look at this. So on this picture, you see a massive pleural effusion. Do you not see this? So up here is the X-ray, right? Pointing an arrow to it. Up here is the X-ray of this patient. You see how the whole right side is just like socked in. It's just completely whited out, right? Is that very diagnostic? Do you know if it's in the lung, outside the lung? Do you know from looking at that X-ray? It's very hard to tell. Okay, you even see tracheal deviation away, which actually sort of is a hint. If the trachea deviates away from the area, then it's probably extrapulmonary. So actually we have a little bit of a clue there. Now when we look at the CT scan, is this not more clear? You see the outline of the lung? Yeah, this is the outline of the lung. And then over here, here is the parietal pleura. So all this stuff in here is pleural effusion. That's pretty crazy, right? So you can actually see a lot better what the volume is too in there as well. You can see if it's a 4-liter pleural effusion or a 500 ml pleural effusion. Here, this one's pretty massive. And then this is just the anterior view on the CTs. Here you see the heart, right, and all that stuff. Here is the top view. Remember the sternum's up here. The spine is at your 6 o'clock position. And here, remember, which lung is this? Hopefully said this is the right lung. This is the left lung. So then you can see the outline of the heart here. You guys see this? That lower left picture I'm trying to outline here. And so all this stuff in here, it's just massive pleural effusion. And then this is the side picture here. Remember the spine is back here. The sternum is up here, so the patient's face that direction. And then all this stuff that's in here is just massive pleural effusion. So massive right-sided pleural effusion, which is more common because, why? Remember, there's less lymph tissue on your right side than your left side. Oh heavens, what's going on here? So when we're looking at this picture, what do you see? So hopefully some of you are like, this is a neonate picture. It is a neonate x-ray. And this is just an x-ray. But what do you see? What do you think this is? Here's a hint. You'll see scaphoid abdomen with that, and hopefully that means something to you. If you were to auscultate on this baby, you would hear bowel sounds in their left side. This condition's more common in their left side. These are loops that I'm highlighting. This would be a congenital diaphragmatic hernia, a CDH. And that's where during lung development, and we'll talk about this in the neonatal class, during fetal lung development, the bowel started to herniate through into the, it's more common on the left than the right, and then that's what's pushing the heart over towards the right side too, so the PMI would be shifted if you were auscultating as well. And so these patients, remember the big thing with these diaphragmatic hernia babies is you don't want to non-invasively ventilate them, because if you cause gastric insufflation, you're actually going to cause more pressure and push less lung tissue to ventilate, so it can be pretty detrimental. So that's why they're intubate first. You do not CPAP or give them non-invasive. All right, so what are we looking at here? Have you guys hopefully oriented yourself to what we're looking at overall? We're looking at the front picture here, and here we see the trachea moving down. We see it go to the right upper, lower, middle, and here's the left. Yes, I know this is not switched, unfortunately. And here's the descending aorta. Here's the kidneys down here. Hopefully you guys start to see this in here. You can even see the spine down here as well too. So over here would be the sternum, this direction, and back here you can even see the scapula, and then the spine would be back here. And so one of the things that you're seeing here, and this is a good example, we had a lot of these patients, I've seen a lot of these patients, this is a herniation through the diaphragm. So this is in adults, and then here's the diaphragm on the picture on your right. I'm highlighting it right now. And you can see there's this little hole, and then things have herniated through into their thoracic cage. And that's what you're seeing here. You're seeing some herniation into the thoracic cage that's restricting that left lung from expanding. So obviously it's a restrictive disorder. Their volumes and capacities would be low. They would have difficulty breathing pretty easily, especially with ambulation. So you're going to see that here and there. So if you look at a CT scan or on this type of situation, you should be like, I've seen this before. Does it look like a herniation? And that's why I showed you that CDH picture. That sort of gives you an X-ray picture of what a herniation looks like, and look at how much more detail you can see on the CT scan. So you can see how a lot of things are trending towards the CT scan here. But yeah, just herniating up and through and into that thoracic cage. All right, so let's talk about CTs with contrast. So this is an injection that you'll take the patient down to CT scan. As of recording this, you still have to take them to CT scan. I'm hoping they change that day. One day. They'll hook them up in an IV and they'll inject this sort of contrast into their blood, and it's going to look at their tissues and blood vessels in detail. And so we're going to use this as far as when they try to aspirate masses or anything like that, if they're going to do a diagnostic procedure there, or even catheter placement if they really have to put something in detail. They might also do this in interventional radiology as well, so you might have to transport this ICU patient over to IR for stuff like this. It's pretty interesting stuff. CT scans for lung tumors. The thing here with CT scans, it's an X-ray, but remember it's a more powerful X-ray, so it has more radiation associated with it than your standard X-ray. So understand most patients aren't exposed to it day in and day out for years and years and years. That's why we need to wear the lead and have that protective material when we're doing anything with radiology like that. With these patients, their exposure is very, very limited compared to healthcare workers. So always wear your lead there. Don't try to go without it. And they're going to dose the radiation per the size of the patient. So if you're in a room with a small neonate, a newborn that's like barely 500 grams, then you're not going to be exposed to as much chest x-ray radiation as you would an adult that weighs 150 pounds, right? You're going to use more radiation for that type of situation. So understand the bigger the patient, the more radiation they have to use. CT scans for lung tumor, we can actually see the tissue mass is a lot more visible than we can on an X-ray. On an X-ray, it would just show that coin lesion type picture. On a CT scan, we can see it a lot more detail and get a lot better picture of what we're looking at. The cool thing is we can actually differentiate using contrast, right? With contrast, we can see if it's a tumor mass or if it's a lymph nodes, or we can see if they're blood vessels, right? We can sort of tell the difference between all three of these things, which will help give us more information about that mass or that thing that we've seen that was abnormal on their x-ray. So you can see how the CT can be very, very useful here. Instead of ordering a bronch, we might be like, oh, let's do an EBUS, right? And go and sample that lymph node, right? Much, much different picture, right? So they're looking tissue modules that are very, very small. And so we can catch them a lot earlier than even in some x-rays, which is pretty interesting. So CT scans for lung cancer, low-dose CT scans are becoming more and more common out there. So CT scans for people that are likely to have lung cancer, they have a family history, smoking, so on and so forth. They're starting to become more and more common out there, thank goodness, because then you can catch these small cell or the small cell lung cancer a lot faster. Remember, the small cell lung cancer is a lot more aggressive and spreads faster, if you guys remember back in disease class. And for you guys, probably it feels like 20 years ago. But anyway, back in disease class, we talked about small cell and non-small cell. Non-small cell, and small cell is more commonly associated with smoking. It's aggressive, it moves fast, so the earlier you catch it, the better. It's not yet the standard of care, but there's a couple reasons for this. The cost, especially insurance companies, that costs a lot more to have a CT scan. Even though it's a low dose high-res CT scan, it's still a cost. Emotionally, a lot of people feel very mortal, very scared when they're facing something like this. Like they feel very, there's a lot of weight on their chest. It's better than not knowing for some of these people, and for other people they just want to sort of ignore the fact that they could have it, even though they could probably catch it a lot sooner and treat it a lot more effectively. And then finally, the repeated radiation that they would be exposed to if they did this once a year or twice a year. So those are some of the reasons why not to do a high-res or a high-res low-dose CT scan. But however, as of recording this, it's becoming more and more popular for people that have a higher propensity towards lung cancer. What about pulmonary embolism? If we think someone has a massive pulmonary embolism, a CT scan, could it be indicated, right? I'm going to ask you, is a CT scan indicated for this or that, right? And so this is where we're going into all these different things. CT with IV contrast has become the standard for pulmonary embolism diagnosis. Now, still the board exams will still ask you about VQ scan, and we'll talk about that in here as well. But this spiral CT with contrast is going to be one of the bigger ones out there that's going to be a lot better, because then you can see if it's not a PE, what could it be? You get a lot more information from this one procedure rather than just doing a VQ scan. A VQ scan will tell you if there's a perfusion issue or not. And that's it. It won't give you any further information on the lung architecture. However, you do a CT scan for a PE and you don't see a PE, but you see a massive pneumonia going on, then you got that valuable data right away. It's one test, one procedure, and you can start treating the patient sooner and more completely that way. I hope that makes sense. When we do contrast, it completely opacifies, it highlights the pulmonary vasculature. So then if you see a dark area, like I was trying to highlight earlier on when I was talking about a saddle embolism, you see that dark area, that means there's no perfusion, and that's where your blood clot or whatever would be. right? CT angio, you can also look at that as well. In the presence of the PE, the thrombus is incompletely opacified, right? We talked about that. This is what they will term, if you see the word filling defect, that's a fancy word for pulmonary embolism. That's a radiology thing. All right, so what do we see here? And this is a picture, I believe I took this one from your book, and I may not have, I don't remember at this point. Here's the spine, here's the sternum. Which one's the right lung? Hopefully you said this one. Left lung, we're not looking at that here. Here we see the left pulmonary artery. Do you guys all see this? LPA, left pulmonary artery. And do you see the right pulmonary artery very easily? Yeah, you don't see the right pulmonary artery very easily. And then also you see these little multiple filling defects. You see all these little, I'll try to highlight them, these little black areas in here. Those are all filling defects, because remember, this whole area is supposed to be highlighted like the left pulmonary artery. It's supposed to be the same on the right side. But you see all these areas that are dark, that is the blood clot. So we have multiple quote-unquote filling defects, right? And this indicates a pulmonary embolism, right? So the ascending aorta and the descending aorta and the left pulmonary artery are completely opacified. You see how opaque these guys are. And this whole area here is supposed to be opaque, right? Where I highlighted those filling defects, that's supposed to be opaque. It's not symmetrical. That means blood flow is not symmetrical, and therefore your issue is the right pulmonary artery has a massive amount of blood clotting going on. So CTs for pulmonary embolism. You can also look at the lung parenchyma, right? We can also look at the architecture of the lungs too. So if it's not a pulmonary embolism, we could still see if it's something else that's going on. When they give the contrast, it's a rapid administration of the fluid, or the contrast, I should say. Patient participation can help, and that's if they're spontaneously breathing. They'll have them hold their breath. They're going to be a lot better view of the vasculature if they hold their breath. So that's why I have the picture of the fish sort of holding its breath. But when we're looking at these, if the patient is able to cooperate, that's good. That'll help with the filling defect, or it helps identifying the filling defect. But a lot of your patients will probably be on mechanical ventilation, especially if their PE is like a saddle embolism like we've seen on that last picture there. What about CTs in ILDs, right? Remember, there's over 200 different types of ILDs, and high-resolution CTs will show mild changes. In other words, we're going to see a lot more detailed picture of the disease progress, and so therefore we could look at the prognosis and the time frame of different things that are going on with the patient, especially if some of these cases, if they see it like the honeycombing pattern and all those things, they can actually make the diagnosis of ILD without a biopsy. And remember, that's the most accurate way to confirm or to diagnose an ILD is a biopsy, an open lung biopsy. Well, this is getting to the point where they can actually diagnose someone without a biopsy if it's clear enough on their CT scan. Isn't that crazy? It's awesome. That's very good that our imaging is getting to that point. And not only that, we can see how extensive the issue is. We can see how widespread the issue is and where it goes. And if we do want to do a biopsy just to confirm further, then we can also identify an optimal site for that biopsy. What about a CT scan in acquired immunodeficiency syndrome? So remember, with these patients, they have immunodeficiency issues. So these are more prone to PJPs, right? The pneumocystis jirovecii pneumonias. So we can earlier detect these pneumonias. So someone comes in that's immunocompromised, they might be able to do this and actually have a lot better picture than an X-ray and see if there's abscesses or cavities starting to form, especially if there's a fungal pneumonia starting to brew. They can also look for enlarged lymph nodes in these patients, so there's a lot more information they can get if some of these acquired immunodeficiency patients are having those issues. What about occupational lung disease? This is another ILD, right? This is just a fancy way of looking at, remember that whole word pneumoconiosis, where it was like a known cause, like inhaling coal dust, gases like chlorine gas and things like that. So this would be like a pneumoconiosis. Like, what about for occupational lung diseases? Well, you can see changes in the pleura and the lung tissues with this one. So you can actually see how on this picture in the upper right part of the screen, you see how it's showing that opacification up there. You can see that scarring in the pleural, and you can even see it in the bases. You can see that scarring that's starting to form down there. It's pretty bad stuff. So that's pleural plaque that you're looking at right there. So this is a classic case of what's known as asbestosis, right? That's a word I think I used earlier in here where we're looking at fungus, right? And you can see it a lot easier on a CT scan and a lot sooner than an X-ray. So if they are thinking that they might have an asbestosis, they might order a chest CT versus a chest X-ray, or they might do both. What about CTs for pneumonia? Just someone that doesn't have a pre-existing condition, but just someone that shows up to the hospital, hey, doctor, I think I have a pneumonia. Well, CT scans in pneumonias can look at the hyla and the pleura, but usually the clinical diagnosis is made off of an X-ray. And that's still standard of care out there. So if I give you a situation in the future, or patients coming in otherwise healthy, suspicious of a pneumonia, then you're going to want to think X-ray. Just having pneumonia does not indicate you for a CT scan, right? It doesn't mean a CT scan is indicated because you have a pneumonia. In fact, that pneumonia is made diagnosis primarily on chest X-ray. That is the gold standard, right? That's why if you go to your primary care physician, they're usually going to be, if they think you have a pneumonia, they're going to order a chest X-ray, right? That's what we're going to be looking at there. So CT scans for just a pneumonia, no other things that we want to look at. No, don't do it. What about bronchiectasis? Now, I talked about this one a little bit earlier. We also covered this in disease class, which I know you all remember, and you still have your disease chart, so that way you can recall this information quickly. All right. Remember, bronchiectasis causes scarring, right? And it's infective airways. And a lot of these airways are adjacent to blood vessels, and so that's one of the reasons why they can get bloody sputum. They can even get what's known as signet ring patterns that show up pretty easily because of the blood vessel. So that's something that they're going to be able to see on a CT scan a lot more effectively. That's why you have to have a CT scan with bronchiectasis. So CT scan for bronchiectasis, yes or no? Hopefully you said yes. All right, and then here's the pictures, and I believe I took this from your book, your Wilkins book, and here you can see those are those signet ring pictures that they were talking about, and how much destruction of tissue is going on down here. But here, A and C, you can see that. B and D, you can see that too. It's pretty crazy. What about COPD? If someone has a diagnosis of COPD, is a CT scan indicated? Well, that's a good question. Diagnosing emphysema using a chest X-ray is about 65 to 80% accurate. Now that can change from year to year, or from 5 years to 5 years, right? It's variable. That's why it's such a huge percentage range. You would see pulmonary hyperinflation. You could see bullae start to form. Remember, those are those little aneurysm pockets that can form in the tissue because the tissue is just starting to get necrotic and dying ultimately. But if you do a CT scan, so this is X-ray, right? And then down here is CT scans. The diagnosing accuracy is up to 90%. However, a lot of times, and this is one of the big things with chest imaging, imaging doesn't correlate with clinical presentation too. So there is some variability with this. So CT scans can be used to sort of diagnose someone if they haven't been previously diagnosed. However, it has to correlate with clinical bedside features, like their obstructive flow rates, things like that. So here is a CT slice of someone with pulmonary emphysema. So this would be your smoking emphysema. This is not alpha-1 antitrypsin emphysema, because remember we're in the apices here, and the alpha-1 antitrypsin protease deficiency is more in the bases, right? So when we're looking at the apices, this is when we're looking at this patient that has a lot of cysts, and you can see all these like bubbles. Do you see all these little things? Right? They got some arrows pointing to them, highlighting them. That almost looks like a honeycomb pattern, but it's not quite. These are just all like Bleb's Boule honeycomb type thing. Right, like I said, remember there's little aneurysms of like necrotic tissue going on. So they're all over this place, and I could spend all day circling all these. And hopefully you'll pause these and look at your own in here too. And so you can see a lot of, we don't have a lot of blood flow. We're losing bronchial vesicular markings. This means that capillaries are getting destroyed from chronic hyperinflation that's associated with this condition as well. And that's why it's more radiolucent as well. We got airflow, but we don't got blood. And that's going to be a big issue for them. And so it's going to be mostly in the pleural spaces to start off with. Remember, it starts off on the perimeter first and then works its way in. So hopefully that's just a little big picture of CT scans, and then sort of CTs in different disease processes, and yes or no for different disease processes. So it gives you a little bit more orientation and information. So when you're looking at CT scans, you're not starting from nothing. At least you have some basic look to them. So let's talk about MRIs. MRIs are going to be a whole different beast. Remember this one, the patient can't have any metal. You can't have any metal if you're going in there, especially if they're on a ventilator. This can add some complications. It's not too bad overall, but just remember, you know, your whole metal thing. Like, don't get the people in radiology upset with you. MRI is limited in diagnosis of lung disease. I'd remember that. That might be something that I would ask you in the future. And then this is the reason why I would stress this, right? And I'll give you a purpose for this, is the board exam will try to get you on this. They'll be like, which of the following would you want to order? And like, let's say this is a ClinSim situation. Which of the following would you want to order? And it might do a lung MRI scan. You're going to know because Derek stressed this, and hopefully you remember it. For diagnosis of lung disease, MRI is not the best as of currently, right, as of recording this. Rarely better than CT scan. You can do IV contrast with it. You can do a simultaneous CT PET scan that you can actually do as well compared to an MRI and still get very good imaging. And I have pictures later on in the presentation of a CT PET that's overlaid with a CT scan, a PET scan that has a CT scan overlay on it. So you can get a really good picture of the lungs with the CT scan that's combined with a PET scan compared to just an MRI. And that's what it's trying to say there. If I do a CT and a PET scan and then overlay those images, I'm going to get a lot better picture than a lung MRI. So not commonly done for just the lungs. Some cases that's the only way that they can do it, especially if someone has chronic kidney disease and they can't get contrast or something like that. So contrast in cardiac MRI has become a tool to diagnose heart disease. So if you want to do an MRI for heart disease, that's a whole separate issue. That's where we can get really good pictures there. So MRIs, remember the big thing here is a lot of these people are, we have to get all the metal and everything off, and we can't take anything metal in there. I'm going to stress this. It says use end-tidal CO2 if available. I hope it is, because the magnets are so powerful in these things, and you're even going to have what's known as Gauss lines, where you have to keep the ventilator behind this line because it can mess up the imaging. When you're doing this, I strongly recommend some way of looking at end-tidal CO2. I'm not talking about the color change, right? I'm not talking about qualitative. I'm talking about quantitative. Something that gives you a waveform and a number, right? And the reason why I want that, and that will correlate to the wireless monitor that you're looking at in the MRI sort of area with the MRI specialist, is That's the only way to tell that they still have perfusion. That's the only way that you can tell that their ventilator is still connected, that they're still ventilating. Because what happens with the EKG, the MRI safe EKG during some of the scans, it goes away, it goes crazy, it gives you this weird reading. So you can't tell if the heart's still beating based upon the EKG. You could cycle a blood pressure, but by the time you cycle blood pressure, let's say every 5 to 10 minutes, let's say you're cycling the blood pressure, that could be 5 to 10 minutes they were disconnected from the ventilator, especially if they have really poor lungs or heart hemodynamics. That could be detrimental. Let's say you can cycle the blood pressure, heart rate's not going to be something you can follow, pulse ox is not going to be something you can follow because that goes away with some of the imaging as well. Like it goes haywire and you can't see that. The only thing on these patients that is not affected as of recording this by by the magnets and all that stuff, as far as the waveforms that you'll see on their monitoring equipment, is the end tidal CO2. I know if I'm seeing the changes in end tidal CO2, then A, they're still connected to the ventilator because I'm seeing those changes, and B, there's still blood flow going to them. Because remember, you're not going to get end tidal CO2 if their heart stops, right? There's no blood going to the lungs, their end tidal CO2 will drop. And so that's a big thing. It tells me about perfusion and ventilation. And that's why I'm a big stressor. If you have the ability to use end tidal CO2 in an MRI situation, I would say use it, right? I don't see any reason currently why you would go wrong in that situation. But I guess that's sort of my own bias put in there, and I hope that I sold you on it, right? You'll be your own practitioners, right? But I want you to sort of see how valuable that this is, both a cardiac and pulmonary evaluation of your patient. So I'm a huge fan of end tidal CO2, and we'll go into it in the future as well. I hope so anyway. Oh, heavens. All right. Other things that you got to be aware of. Don't take any metal things in there with you. And they have those little wands that they'll wave all over you and see if there's any metal. And even the MRI e-tanks, there's MRI safe e-tanks. And usually they have this like little, I'll use gold here. They have this little like gold triangle that says MRI on it. And that means it's MRI safe to take in there. Like you hook that up to the little transport ventilator or the MRI ventilator, and you can take that in there. But you got to make sure it's the MRI safe tank, right? Don't take your regular aluminum tank in there. Then you're going to see a missile situation happens. I had a patient, not a patient. I was with another RT at one point, and I guess his wallet was in his pants, so he always wore his wallet apparently while he was working at the hospital. Maybe he was getting tips, I don't know. But he went into MRI and he still had his wallet in his pants or fanny pack or something, and it wiped his credit cards, so he had to get all new cards and all that other stuff. It was pretty interesting, but it's a pretty powerful magnet. That's what I'm trying to talk to you. So equipment, you gotta have a special ventilator. Obviously, they make MRI safe ventilators. I think we had a Servo I that was an MRI. Then we also have like the little transport pair packs for the more stable patients. So MRI safe tanks, MRI safe regulators, if that is something you're doing. Make sure like implanted devices like pacemakers, right? Things like that, they have to go through this whole process to make sure all that stuff is good to go. Now, most jewelry these days are non-ferrous. There might be some, but a lot of times the jewelry that's in there are like dermals, things like that. Crazy that I know this, but went to MRI enough, you'll get to know all this. A lot of the jewelry is non-ferrous, so you just got to be aware of the jewelry, especially of the nurse or whoever that's going in there, male or female, whoever, right? You just got to be aware of that. Big thing here, empty your pockets. I was lucky enough, I was a fanny pack therapist or a lab coat. My later days, I wore the lab coat, and I loved the lab coat because you just take off the lab coat that has all your junk in it, right? All your stethoscope, your pens, your, you name it, your scissors, all that stuff, all those pockets, and then you just hang it up, and there shouldn't be any metal left over on you, right? So make sure you empty your pockets, make sure you take off your fanny pack. Hopefully it's not the only thing holding up your pants, but we're all healthcare professionals, so. All right, so that was MRIs. All right, be sure to be safe. Don't go too far in there. Don't just run in there. Make sure that you've been checked for metal. Make sure that you do a whole self pat down before you go into an MRI room. Now, glasses are usually okay. Like I said, most time glasses are non-ferrous if you wear glasses, things like that. nucleotides testing. This is where they inject some nucleotide stuff into the patient. We can inject it or they can inhale it, like we see with the VQ scan. Injected is sometimes one of the ones they use for cardiac stress testing. All right, hopefully you guys have looked at that cardiac stress testing. And then they'll scan pre-workout and then they'll scan post-workout and sort of see what areas of the heart have been affected by the heart stuff. So inhaled and injected. And when we're looking at a VQ scan, they'll do both. They'll do a nebulized radionuclide as well as inject it. We're going to compare perfusion to ventilation. That's what the VQ whole thing out. So we're going to compare this. So I'll go over the basics of how to look at the VQ here. And this is the one classically where they'll ask you to diagnose for a PE, and that's that VQ scan that they're usually talking about there. And so we're going to inject stuff into the bloodstream to look at perfusion, and then we're going to nebulize stuff, so we'll look at ventilation. Right, so if we have high blood flow, it will appear dark. Now, the alternate term they use there is hot. I don't know why. That's just the term that they use. If you know, let me know, right? I'm more than willing to learn. I love to know this stuff, like, and why this and why that. Hopefully you guys are like that too. If there's almost no blood flow, they call it cold, probably because there's no blood flow, and therefore it's going to appear cold. So black or opaque. Opaque is cold. Black is hot, apparently. So you're going to see less blood flow with a PE. So it's going to appear cold, right? It's going to appear radiolucent. Yeah, okay. Ventilation, we're going to nebulize the radioactive gas. Have fun. Always test it on your student first, your RT student. Little joke there. Don't actually. Anyway, all right. Well-ventilated patients, you're going to see the area appear black. Poorly ventilated, it'll appear radio opaque or clear. All right. So then we're just going to compare the two. So this is the picture, and I think this is straight out of your book. So over here in letter A, right, we're seeing the lung filling without gas defects, right? So A is looking at the lung filling without gas defects. So over here is the nebulized part. We gave them the neb, and this is the distribution of ventilation that we've seen with it. So pretty good distribution. We got apices, we got bases. Maybe I'll switch to yellow. I don't know if that's much better. We got pretty good distribution. So we're comparing the two. Over here is where they gave the patient the injection. All right. So here we should see this whole area radiolucent. We should see it dark, right? Like we see over here. We should see this whole dark area. But we don't see it 100% dark on all the areas, right? And that's where letter B over here, this is the injection, right? This is what's looking at perfusion. Remember with the PE, you have no perfusion and you have good ventilation, right? So you have good ventilation, no perfusion, right? And so here you see this area here, right? Do you see that? That means that there's no blood flow really going into this area. It's radio opaque or cold. And so that means that's where your filling defect, which we all know a fancy word for filling defect is pulmonary embolism, right? Hopefully that you sort of see that here. So if you're ever looking at a VQ scan, you want to see dark, 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 right? You want to see all the areas dark, and that would rule out a perfusion defect. The fact that you see in this area here that was opaque means there was no perfusion in that area where there was ventilation. So that's the area where that PE actually happened. So it would confirm the presence of a filling defect, aka in this situation, a pulmonary emboli. So hopefully that's starting to make sense. And this is sort of the same thing, just a different way of looking at it. And you might see this where they have the anterior picture and the posterior picture, left, right, so on and so forth. So you can sort of see it in further detail. And you can sort of see the lung, and then this is just the cutout of the heart there, right? The cardiac notch right here, right? Posterior, and you can see, and then you can see a little bit of the cutout of the heart. Remember, the heart appears smaller on a PA film than an AP film, right? So that's what you're looking at here, and you want to see symmetry, right? Don't get the heart confused, but when you're looking at this, you want to see that blackness symmetry in there. So hopefully that was a little good review for the Q scans. And now Gleam scans. This is a different way to look at masses, that if they're highly metabolic masses that the patient has. And then this is where it might be a lot easier to get a biopsy for diagnostic procedures. So if you take a patient for one of these scans, it's what they're usually looking to do, is like where would be a best place to get a biopsy. And one of the best reasons why they usually do this is to help them get a biopsy to confirm or diagnose sarcoidosis. Remember, sarcoidosis can be very difficult. It's one of the ILDs, and it can be very dangerous, and it has a lot of manifestations that can go on with it. So this is where we can look at the lymph nodes, the lacrimal glands, and the hyla a lot more detail. And usually the big thing that this does is it highlights inflammatory tissues, anything that's inflamed, which in these areas, the lacrimal glands, lymph nodes, and the hyla are going to show up prominently, and then we know exactly where to go get that biopsy. So hopefully that makes sense. PET scans. I loved PET scans. Taking a patient to PET scans. Everybody's always happy over there, it seemed like. I guess that might be just where I practiced. All right, so PET scans, pretty much they inject what's known as like sugar water, and it goes to areas of high metabolism. So it goes to high metabolically active tissue, right, that love their sugar. If it's metabolically active, it loves sugar water, and it's going to show up really black or really dark on the film. So if you're metabolically inactive, you're not going to take up near as much, right? So it's going to appear appear cold or clear, right, when we were talking about that on the film. So this is looking at if we see a mass in the right upper lobe, and that's what we're looking at here on this PET scan. If you guys look at this PET scan, you see the right upper lobe has this whole area that's highlighted in the apice there, and that's a sign that that is a highly metabolically active tissue. Not a good sign, but that at least we know that there's highly metabolically active tissue there, so we can start to prepare for, if this is a non-small cell carcinoma, we can start to prepare for either wedge resections or surgical removal, things like that. So PET scanning, usually very, very helpful if we overlay them with the CT scans. So a lot of times you go to PET, then CT, or CT, then PET. It sort of depends on their things. And then they'll overlap the images. Pretty cool. All right. The cool thing about this is they can see how much the tumor spreads. Is it spread to the lymph nodes? Is it spread to their long bones? Has it spread to their adrenal glands? It's a really good way of looking at the metastasis of this condition. Not useful for brain issues though, because you guys should know this by now. Your brain uses glucose exclusively for energy. So that means if your blood sugar is super low, what do you think happens with your ability to mentate? It's very, very low. So if you want to do an experiment with this, make sure your blood sugar is low and then take a test. Not one of mine. Take a test. See how you do. You're probably not going to be doing very good. Now, get something good in your system, get that blood sugar up. You're probably going to have a lot better mentation going on. Alright, so this is a series of imaging that they were just showing an example where they've seen a coin lesion up here. You see the coin lesion? Highlighting it for you. On the x-ray, and you can sort of see it on the x-ray, that coin lesion as well. And so when you look at the PET scan, if you look at the picture at the 6 o'clock, you can see how active that is, metabolically active that is. And so the PET scan is there, and you can see the density pretty darn easily there. Now, just looking at that x-ray, if you did not know that there was a coin lesion up there, would you have spotted it? Right? Do you guys see it? Hopefully you see that. Maybe not. I hope so anyway. So you can sort of see it on the x-ray, but is it a lot more clear on PET scan and CT scan? hopefully it is to you, right? You can sort of see the advantage there. Now this patient also has a pacemaker, so be careful. Some of those are MRI compatible. I think most of them nowadays are, but that's a whole separate thing. So don't be distracted by that. That's what it's saying in the description below. And then you can see how metabolically active this is. That means this lesion is metabolically active, which is not a good sign. It means it's usually a cancer that's going on, right? It can be an old scar. If it wasn't metabolically active, then that might be a differential. Is it benign? If it wasn't metabolically active, that might be a differential. However, the fact that it's metabolically active means that it's probably not an old scar or benign tumor. So you can see that how it lights up. It's probably a metabolically active tumor. All right, so you can sort of see the advantages of overlaying a CT scan and a PET scan together. A lot more detail, a lot better information, especially if you're trying to diagnose something like lung cancer with some of these patients, or where it is, or if it's spread and things like that. Chest ultrasound, more and more common. I hope you guys get trained to do this. I think RT is a prime discipline for lung ultrasound, especially in critical care and in emergency medicine, especially there. Even on floors, I think RTs could eventually spread to the floors to look for things like pleural effusions at the bedside, stuff like that with chest ultrasounds. That's just my own personal wish, I guess. Chest ultrasound is pretty harmless to humans. High frequency waves. It's portable. You can use it at the bedside. Great for really sick patients, especially if you think they have a pneumothorax, pleural effusion, things like that. This patient's too unstable, too much high oxygen requirements, too much vent requirements to take them to a CT scan, all that stuff. You might be able to do a quick bedside ultrasound to help you diagnose or to place that chest tube, things like that. So advantages, applications. You can see why I'm so happy and giddy about RTs going into this. A lot of applications, right? You can see if there's a pleural effusion and how big it is, right? You can actually use it for needle placement during thoracentesis, so we can actually mark where they would actually do this. They can use it for catheter placement during chest tubes, right? We can make sure it's going to the right place. They can use it for putting in central lines. That's just something our RTs do, right? Oh, thank goodness. I hope you guys are some of the people that want to go into stuff like this. Further assessment on chest x-ray. In other words, we can see if a patient has a spinal cord injury, we can see if they have unilateral diaphragm paralysis. We can see if the diaphragm is moving, how much. We can see if there's a pneumothorax, especially at the bedside, especially in critical care, especially in emergency care. We can see ET2 placement with it. It's pretty cool stuff there. So it's right there at the bedside. We can use it. We don't have to wait for an x-ray. And then we can also look for, hey, the function of the heart, especially when we're looking at things like ARDS, and if there's left ventricular function, or how bad the left ventricle is how good or bad the left ventricle is functioning. Remember, if the left ventricle is super sick, it's probably cardiogenic pulmonary edema, not ARDS. All right, let's talk about fluoroscopy. Real-time continuous images, you have to wear lead for this, of course. So wear it over your thyroid, wear it over all your other parts that are being exposed. And this is where they use a needle or a catheter to guide something into a specific place. Most commonly, you're going to see this in cardiac cath lab. And then we'll do bronchs with this as well, where you have to wear lead. It just gets really hot, so be prepared for a little bit of sweating action, at least if you're a bigger person like me. But bronchoscopy, usually you could establish a good position of the scope with it and sample a certain location that you might not be able to see underneath from direct visualization. So it's pretty cool. So you could see a mass on the fluoroscopy screen and then not see it in your visualization screen and then still be able to sample it. It's pretty cool. A lot greater radiation. All staff must wear protective lead. And then if there's a possibility of the staff being pregnant, they probably should not be there, so switch out. All right, radiation safety. This is one of the big things that I have to just make sure to go over with you. I want you guys to be healthy the rest of your career. Large doses can be harmful, so the more sophisticated the study, the more radiation in theory that you might get. So just be very, very careful. Standing outside a room while they're getting an x-ray can still give you some radiation. I always hid behind the x-ray tech. I'm just joking, somewhat. So try to avoid it as much as you can. It can be harmful over the decades, right? Over like 20-year career or something like that. If you're performing or assisting with a lot of these bronchoscopies that use fluoro, then that's something just to be aware of and just be cognizant. Make sure you're wearing the lead. Make sure if you've gone through a lot of these procedures lately that somehow you sort of switch that up. But anything that has is real-time images like fluoroscopy, more radiation usually. You gotta wear your lead. Neck, right, that thyroid shield, abdomen, pelvis, right, go crazy, right, get as big of that stuff as you can find it.